Good afternoon, everybody. Thank you for being here on November 13th, 2024 for our ins and outs of remote patient monitoring, economics, billing, and compliance webinar. I have a tremendous slate of panelists and speakers who will introduce themselves to you momentarily. In the meantime, my name is Luke Wortley. I'm the program director of the Upper Midwest Telehealth Resource Center, a program of the Indiana Rural Health Association. And before we begin, I would like to just do a few pieces of housekeeping. If you do have questions throughout the presentation, we ask that you use the Q&A function, which will be monitored by myself as well as our IRHA staff backstage. We're going to tentatively try to answer questions at the very end of the didactic and content-based portion of this before we begin our panel discussion. This is scheduled for 50 minutes. With 10 minutes left for discussion at the end, depending on how organic things go. We are ready to get kicked off. I would like to, before we begin, thank you for our support from the Illinois Hospital and Health Association, the Illinois Primary Healthcare Association, and the Illinois Association of Healthcare Attorneys. So without further ado, I would like to go ahead and hand it off to Donna McHale, who will walk us through the agenda today and then introduce our roundtable of speakers. Donna?
Donna, we're not able to hear you.
Luke, we can't hear you.
Oh, there we go. We can hear you now.
Oh, did my intro not get picked up?
No.
Participants, can you hear? Because our backstage participants won't be able to hear while they're backstage, but our audience should be able to hear. Okay, our audience can hear. Good, great.
Okay.
Okay, wonderful. I'll hand it off to Donna now.
Great. So you're handing it off to me for the agenda? There we go. Hello, everyone. Welcome to this afternoon session. I'm going to be your moderator today. And as you've heard Luke say, we have an amazing group of speakers and panelists. So let me tell you a little bit about how it's going to go. First, we're going to have Matt Drew talk to us a little bit about reimbursement, coding, and billing for RPM and RTM. And then we're going to move to Bernie Bonassa, and Bertie's going to give us some considerations for RPM business cases. And then after that, Rick Hindeman is going to go through some compliance issues and facts and considerations that we need to have for RPM and RTM. And then we're going to have a lively discussion with our three speakers, and then we're going to add Mike Sisti to it from Silver Cross. So let's go to the next slide with our introductions. And how about if we tell you a little bit about ourselves? So I'm Donna McHale, and as I said, I'll be your moderator, and I'm a principal at Huron Consulting Group. Bernie?
Yes, good afternoon, everyone. Good morning if you're joining from other time zones, like maybe the West Coast. Bernie Bonassa here, VP Provider Solutions at Care Simple. We provide RPM solutions to provide organizations. Nice to be here.
Great. Matt?
Hello, everybody. Matt Drew, CEO of Alpha Omega Health. We are a virtual care provider.
And then Rick?
Hi, I'm Rick Hindman. I'm a healthcare attorney with the McDonald Hopkins in our Chicago office, and I'm also on the program planning committee for Partnership for Connected Illinois.
Great. And Mike?
Mike Sisti, Admin Director of Silver Cross Hospital, Managed Care.
Great. Well, welcome, everyone. So now as we move forward, I think we're going to get started with Matt. Matt, we're going to turn it over to you.
Very good. Well, we'll make this kind of quick because I believe you guys will also have access to this. Going to cover a couple of the keys and ins and outs of billing and coding as it relates to remote monitoring, both the remote monitoring programs as well as remote therapeutic monitoring. As you can see up there, there's quite a few differentials between the two. Remote patient monitoring being for one or more disease states. It can be done under general supervision, which is important for those that are working with a multi-tier licensing staff or qualified team that is managing the alerts of the devices. These codes in particular are related to the setting up an education code. So those one-time codes for setting up, so 99453 being related to your remote patient monogram, 99473, which is related to hypertension and self-monitor blood pressure. And then, of course, 98975, that is going to be related to the remote therapeutic programs that are going on from your patients. It is a one-time fee, so it helps kind of stand up the educational component of it, as well as any kind of helping install or anything of that nature for the devices that are going in place. You can go to the next slide. Go back a couple. One more. Yep, there you go. These are the codes that are going to be related to the actual transmission related to the devices themselves. So 99454 is related to the every 30-day billing code, 16-day minimum. As you may have seen, there are some updates coming in 2016 where they'll go down to two times within a 30-day period. But for the time being, making sure that you're at least receiving a reading from an FDA cleared device at least 16 times within a 30-day period. This is going to be reviewed by your clinical team with oversight from either your physician or nurse practitioner. And then, of course, you have 99474, which is related to the self-monitoring blood pressure cuffs. This is, again, going to be done by your physician and nurse practitioner, 12 days of readings. The big difference here is that you have to take 2 subsequent readings within a 1-minute period to count as, quote unquote, that 12 reading per 30-day period as it relates to that. And then, of course, you have your remote therapeutic monitoring has a couple different ones as it relates to the specific types of conditions being monitored, respiratory being 98976, as well as your MSK is related to 98977, and then anything from the cognitive behavioral standpoint, which is your 98978. Again, those have 16 minutes related to them in minimum in terms of a 30-day period. These must be FDA approved devices for that. And they're primarily working again in the musculoskeletal and or respiratory space. So they haven't opened it up to multiple conditions yet. And then, of course, the cognitive behavioral side. You can go to the next slide. These are the professional codes. So for the actual time for you and your team, depending on who the billing practitioners or team members are that are going to be making up the clinical time related to the different monitoring programs, all are under, in terms of remote therapeutic monitoring, remote patient monitoring, they are going to be general supervision. So that could be your staff that's working with you, other nurse pracs or PAs, as well as nurses and other team members that are helping facilitate the care. It is noted you will want to, when it comes to triage, work with the nurse level or higher that is going to be doing that, but other capabilities that are going on for the programs, you can work with your team. And then, of course, 99091 is which is directly supervised by the nurse practitioner and or physician. This has different time slots that you can have. So there's the initial 20 minutes. That's going to be your 99457 for remote patient monitoring, and then up to 2 additional 20 minutes for 99458. And then, of course, for remote therapeutic monitoring, similar type of setup, which the initial 20 is 98980, and then any subsequent is going to be your 98981. For the programs which are going purely in the remote patient monitoring for the patient done by the physician or nurse practitioner, it's based in 30-minute increments, as you see there. You can go on to the next slide. Other key things to think about are the principles for this. So you do want to be able to have FDA regulatory devices. There are some where you, within the qualified for the self-managed blood pressure. This is important. This is one of those areas that in terms of an audit, you want to be able to have documented proof that your devices that are being used for managing the specific devices or specific conditions are FDA. Want to be able to check for eligibility of the patient, both from an insurance perspective, but also that they do have the medical need for being implemented into the program. You can go on to the next slide. Patient consent, as with all programs, you always need to gain consent of the patients. Need it documented for verbal consent, but also ideally in writing if you are able to obtain that for the patient. We'll talk about some ideas of how to maybe streamline this process later on in our panel discussion. As mentioned, medical necessity is required. This is a strong point that came out in the OIG letter about making sure that the patients don't just have the conditions, but that they need to be managed so that they have medical necessity. And then you also need to have a treatment plan with a course of action for what's going to be done for the patient as well as for the provider during that period and what conditions. You go on the next slide. As you can see here, there's a couple of things. We already covered the communication standpoint for what it means in terms of real-time synchronous communications with the patient. You do need to have at least one interaction with the patient monthly in order to qualify for this. In the past, sometimes people have tried to review alerts without communication. You do need to make sure that you actually have interaction between the patient and or caregiver. Only one paying practitioner per patient is billable during any period. And then, of course, with the concurrent billing, RPM or RTM cannot be billed at the same time. While RPM can be billed with things like chronic care management at the same time, RPM and or RTM are the selection for the patient, depending on what program you're going to enroll them into. There are limitations to this, obviously, no double counting time, not on the same day of any kind of E&M service. And as mentioned, you cannot bill those in concurrence. I'm going on to the next. Go ahead, Bill. Bernie's now going to talk about the considerations for business cases for implementing a remote monitoring or remote program.
All right, thanks a lot, Matt. Appreciate the good background there on all those billing codes. Yeah, so what I'm going to be speaking to is the business case overview for RPM, which would be inclusive of a lot of the reimbursement discussion that we've had up to now, but also then looking even beyond that for other types of non-reimbursement models or other types of considerations outside of just reimbursement. So really, when developing a business case with our clients, we see it's the most important step really being up front. How do you want to align your financial objectives with a variety of things? One being the incentive model. Are you being incentivized in a fee-for-service model that's reimbursement-based, or is it a value-based care program, or is it some type of combination? Are they aligned with patient disease conditions that you're trying to monitor? Because those can have an impact in outcomes and measurement. What's your payer mix? Are you dealing with Medicare, Medicaid, private payers? Because the reimbursement rates will obviously vary and the coverage across those. And then maybe also looking at stage of care. Is this a short-term program where you're just monitoring 30-day readmissions in a transitional care program? Or are you looking at improving health conditions, chronic conditions over a long period of time and doing a long-term monitoring period? Then next we look at revenue opportunities. What are the available reimbursement revenue opportunities, especially, and not just RPM as a standalone program, but you can stack other programs with it if you're doing all the right time components for each program. So RPM and CCM, for instance, could be billed concurrently for a given patient in a single month even. And then we look at other types of things like the staffing model. Is it how are you going to be staffing the program? Is it centralized in your organization? Is it more distributed in your organization? Is it fully in your organization, or is it being outsourced? Some of the staffing, or potentially all of the clinical monitoring. And then we look at measures such as how emergency department utilization and hospitalization will be measured in terms of outcomes from the RPM program. And in the hospitalization area, we look at both admissions and readmissions, and what are the goals there in terms of those measurements. Additionally, will the program outcomes be measured for impact on quality measures, such as 30-day readmission scores and HEDIS scores, and how does this lead to financial incentives in those programs and or penalties, right? So how do you optimize and maximize the revenue retention through those measures? if they're being included. We also like to look at other types of downstream financial outcomes, such as in patient satisfaction, retention of patients, and even increased patient volume through program outreach, highlighting the outcomes of a well-running program, a high-performing program. Obviously, there's other softer costs that could be viewed as clinic and staff efficiency, reduce stress on staff, basically because you're smoothing out the episodic events and having a lower frequency of those as well for patients, especially high-risk patients and high utilization patients. Finally, we look at how can we drive the financial outcomes at scale, and by working with our clients to streamline the workflows, the operational processes, including full integration with the EHR, and getting that use case adoption to scale because of the improvements in workflows and processes. So these are all considerations that could come into play individually or together. So for the first business case we want to look at, going into actual examples of business cases, is here. We present first a fee-for-service model. This one's viewed entirely based on revenue, reimbursement revenue. So what we're using is the assumptions on the right side of the slide here. We're looking at a program example of 200 patients, and realizing also there's never a 100% perfect achievement for billing eligibility activity across all the patients in the group. We always apply a reduced percentage achievement level that we find that's typical of our other clients, and can easily be adjusted for the specific situation. In this case, we're using a 75% achievement level for patient compliance with the minimum 16 days of readings to bill for 99454 that Matt spoke of before, and 80% achievement level across the patient group for billable time under 99457 for the first 20 minutes of professional service time, and 25% level for the second 20-minute block, which is filed under 99458. So when we apply these achievement levels to the billing amounts, you'll see the billing reimbursement levels based on the 2024, soon to be changed in 2025 slightly, but 2024 physician fee schedule using national non-facility rates. You can see the rates there for the different codes. And then the billable events are essentially calculated across the group of 200 patients for the annual 12-month period. And we get, using the calculations, the reimbursement amount per code, and you'll see the total reimbursement there. Then what we do next is we back out the RPM system costs, and we've used an average program cost here for typical among vendors in the industry, and included the program setup fee. And then we end up with the net reimbursement before staffing of the RPM program. As you can see here, it looks very positive based on these numbers. And we like to stop at before staffing, because a lot of times when we talk to our clients, the staffing may or may not be fully loaded into the model. It could be that the existing staff that's handling a lot of inpatient visits, a lot of episodic events, a lot of working with patients that are bouncing back and forth to a hospital or ER, and their time is consumed quite a lot with the episodic events. But as you roll in RPM, then they can smooth out and handle really a staff that was handling the same patients in office, and all those episodic events could be easily swung over to manage a high number of RPM patients, and much more efficiently with less episodic events. And you're just using the same staff, but in a much more improved and more productive way. But when our clients do want to take a look at, hey, let's load the staff hours in there, or if they're asking, well, if we're going to use an outsourced staffing model, what would that look like as a tax on the program? So we end up looking at a certain amount of admin hours for the program, and then we also calculate the exact usage of staff hours tied to the billable activity time that we're showing for the number of patients times the amount of time spent. We use an average hourly rate for nursing time in the country, and we come up with a total staffing picture, and then can back that out. And you'll see here still it's a positive business case in this scenario with the staffing loaded in. All right, next slide. And then now we're going to look at an example of a value-based shared savings arrangement payment model. And we're going to, this particular business case factors in really only emergency department avoidable utilization and avoidable hospitalizations. There's other measures that we could include in the program, but these are the most identifiable and easy to come up with for this analysis. But you would maybe then also typically look at what other financial outcome measures in the area of 30-day readmission scores and HEDIS quality measures may also be factored in that could improve the outlook. So for this model, we took 200 patients in each a heart failure and a hypertension disease group, patient group, and looked at the financial summary is at the top. That's fully rolled up from more details below. It's interesting that you can see here that we've got the top line that'll be a cost savings from RPM that's calculated below. And then in a 50% shared savings model, the shared savings would be half of that to the provider. And then you back out the similar RPM system costs that we had used before or adjusted slightly for this program, and you get your net revenue financial gain or loss in the program per year. And as you'll see, there's a note here that's kind of highlighting that while hypertension itself is not a high contributor to hospital and ED utilization, which is why we're showing, you don't really get a huge amount of savings here. As shown in this analysis, it's often linked to other comorbid conditions, and it also has many downstream impacts and costs to the health system if not managed. So that you can really, when you do start looking at the additional analyses and inclusion of some other performance-based incentives around, again, the HEDIS scores, and that you could attach some more savings to the health system for hypertension management, and that will show a more positive outcome. But a lot of times what we deal with a lot of our clients is they have multiple programs and are looking at hypertension and heart failure and COPD or diabetes or something. So it's a blended program that still comes out highly positive, and you're sort of able to keep those hypertension patients healthy as part of a healthy financial successful program. Without going into too many details here, we have the heart failure kind of breakdown first showing, and then hypertension below it. And essentially we use studies to come up with, it's been proven that RPM can save 20% of hospitalization among a heart failure group. And it's typical to see 50% utilization, hospitalization under a heart failure program. And with a 20% reduction, we take it down to 40%. And using that math, we then go through and look at how many hospitalization events, including a reduction of hospital length of stay by 1 day, which is again backed by studies we looked at. And you look at a hospitalization cost, which basically takes the number of days times the hospitalization cost rate. Do the same thing with the ED utilization rate with a 20% savings, and we map that out into a total for hospital and ED utilization comparison and savings. And that's how that gets factored into as one of the components in the cost savings for RPM above. We do the same thing with the hypertension. And in this case, it's assumed that with an uncontrolled hypertension population, there is no controlled hypertension among that at the start of the RPM program. And you end up with a 50% improvement in half the patients achieved a controlled hypertension stage. So we apply that 50% improvement rate kind of through the math for hypertension, and that feeds into the savings above as well. So that's there's a lot more detail behind this, including the studies that have been used and the rates for hospitalization and ED utilization in terms of dollar amounts. But obviously, we're always available to go through specific use case models, but this is simplified here for this presentation. So in all, it shows that in a value-based shared savings model, there's considerable financial savings that could be generated from RPM. And I think we're turning it over. Is it to Michael at this point?
Oh, it'll be to Rick.
Rick.
To me. Thank you. So Matt discussed the billing requirements for remote patient monitoring, both RPM and RTM, and Bernie discussed the some of the financial issues to consider. I'm going to provide a fairly quick overview of some of the compliance issues to keep in mind when providing remote patient monitoring. So just recently, it was a little under 2 months ago, the Office of Inspector General of the Department of Health and Human Services published a report recommending that CMS expand its oversight of remote patient monitoring to ensure the services are properly used and properly billed. As a matter of fact, it's a 30-page report. The title of it is Additional Oversight of Remote Patient Monitoring in Medicare is Needed. And CMS, the OIG mentioned several things. One is to kind of put things in context. There was a huge increase in remote patient monitoring, remote physiologic monitoring, which was really what the focus of the report was. There was an increase in RPM, the number of patients receiving RPM between 2019 and 2022 increased by 10 times. And the amount paid by Medicare for the RPM increased by 20 times. So you've got a situation where the RPM's being used more and more. And the OIG observed that the ability of CMS to ensure that billing requirements are satisfied, that ability was hindered by a lack of information regarding remote physiologic monitoring. And they mentioned lack of information on what the devices were, who was ordering it, who the servicing providers were, data collected, also conditions monitored. And the report revealed that the OIG is examining remote physiologic monitoring and intends to identify RPM billing patterns that may be indicative of fraud, waste, or abuse. So kind of suspect factors. So stay tuned for that document that should be coming at some point. The OIG makes recommendations that CMS strengthen its oversight of remote physiologic monitoring. One of the things that they ask CMS to take a look at is to identify providers who frequently bill for patients, but situations where the patient doesn't get billed for the 3 companion codes. So Matt talked about the code for initial setup, and then for monthly supply, and then monthly management services. And so the OIG was concerned that there were situations where they didn't match up. Patient receives one of those services, but not the others. One thing that I think is kind of curious about that, though, is that there are very good reasons why providers in some cases wouldn't bill all 3. I mean, the initial device code for the setup is a nominal amount, around $19–20. And and then it's very possible that if the 16 minutes of time isn't 16 days of recording isn't there, they couldn't bill for, the provider can't bill for the supply code. And if there are fewer than 20 minutes, the provider can't bill for the management code. But yes, so there are good reasons sometimes not to do that, but CMS or the OIG seemed to think that that's a little bit of a concern. So one of the takeaways, I guess, that I have here is that I don't view this as a report that kind of is a need for alarm. But at the same time, it did signal that the Office of Inspector General viewed RPM and RTM as situations that really deserve more scrutiny. And so one of the things that very often happens when there's more scrutiny is you sometimes have more audits. And just more attention paid to the issues and potential concerns. So that's kind of a reinforcement of the need to go out and to have to pay attention to the compliance issues. And I'll also mention there were a couple other developments within the last year that involved issues. That there was a consumer alert that kind of focused on medical necessity, billing for services not provided or not needed, and also a a false claim settlement involving a higher level of remote cardiac monitoring than what was needed. Next slide, please. And then, so one of the things that's going to be important is, especially to prepare for the possibility of audits at some point, is Matt mentioned the billing requirements, the billing elements for remote patient monitoring under the CPT codes. And so it'll be important to have documentation in the record showing that those CPT elements were satisfied, that there was appropriate supervision, and that the other requirements were satisfied. And then if you, especially in situations where you have third parties involved, like maybe some kind of a collaborating partner or a vendor involved, you potentially have issues of perhaps corporate practice in medicine. For example, is the vendor or the non-physician personnel maybe stepping over the line, doing more than what they should be doing? And also fee splitting issues, which can depend on state laws, because some states' laws limit the ability of physicians to share their fees, to, let's say, pay a percentage of fees. So you need to look at the way the fees are structured as well. Also, self-referral perspective. It's important to look at arrangements with third parties, especially if a third party can be helping to increase generate business, increase the business of, could the arrangements be viewed as some kind of a kickback violation, an incentive to make referrals? And also, I'll just mention, I'm not going to get into detail, but some of the RTM codes are designated health services under the Stark Law, which means that some of a lot of the RTM procedures are governed by are covered by the Stark Law. So it's important to examine like what the referral relationships are, and to satisfy, to the extent there is a referral relationship, to satisfy requirements under the Stark Law. Next slide, please. Now, in terms of privacy and information security, you've got the typical issues that apply in terms of needing to implement safeguards to protect the privacy and security of PHI, protected health information. Particularly if there's relationships with third parties like vendors or collaborating partners that are involved, and then they have access to the electronic medical record, patient information. You need to have risk analysis and risk management involved in terms of how does this change the potential risks on the privacy perspective. Also consider what rights, particularly if a third party is involved, what rights does the third party have? For example, does the vendor have a right to de-identify the patient information, the PHI, and to use that information? Who has the rights to that information? Also, does the vendor, for example, have the ability to go out and aggregate data? So, for example, which be a situation where a company can maybe that's dealing with multiple providers, they may be able to to combine information from the various providers and kind of compare and kind of do some benchmarking and get some important information. But you need to think through what rights do the parties have for that. And also, if there is a third party, there's a business associate relationship, and there needs to be a business associate agreement. Next slide, please. And so, these kind of the concern about these compliance issues and satisfying the billing requirements and other elements makes it important to have adequate policies and procedures. So and I list some of the elements here. I'm not going to go over all of them, but it's important to identify, determine which patient should be getting the services, to make sure that there's patient consent, keeping in mind there needs to be evidence in the medical record of the patient consenting, and also the patient acknowledging copay obligations. communication with patients. There needs to be at least one interactive communication in a month if there's the billing for the management codes. Also, it's important to have information to make sure that there's adequate supervision, that the physician or nurse practitioner or physician assistant who does the billing provides sufficient supervision and also confirms that there's medical necessity, that the services are needed. Also, if there's a vendor involved, a third party involved, keep in mind that the Medicare prohibition on the payment for services furnished outside the U.S. So if someone is actually doing the monitoring and outside the U.S., there may not be the ability to bill Medicare, or also if these people are excluded individuals. So those are safeguards, I think, for the agreements with a third-party vendor. And then kind of threshold levels for the readings, and a process to escalate the issue if the remote patient monitoring shows that there's, let's say an issue that needs to be addressed. Next slide, please. And part of the policies and procedures should deal with documentation, of having adequate documentation in the medical record. So if there's ever an audit. And I do list some of the things there. It's important to have evidence that there's someone who actually ordered the service. What's the condition of the patient? Is their medical necessity satisfied? Is there consent? I mentioned that earlier. And also, Matt touched on kind of the counting of time, but keep in mind for these codes, time can be aggregated. It doesn't have to be 20 minutes all at once, but you can't duplicate time, and you also can't round up, and you've got some services you can't bill at the same time. So it's important to have that documentation involved. So I'll turn it over to Donna for our panel discussion.
Donna, if you don't mind me interrupting ever so briefly, I'd like to ask all of our speakers assembled. We had a question come in from the chat. For a fee-for-service model, like what % of RPM claims are denied on average? And if you don't have that like specific number, that's okay. But the questioner also adds that we factor that into our financial models for a lot of different programs. So maybe if somebody could speak to denials and how to potentially account for that.
I can take that since the crowd hasn't heard from me. Again, this is Mike Sissy from Silver Cross. I wouldn't say I have a specific denial number, but I can tell you that depending on the type of payer is where we've run into our instances of running into denials. Usually traditional CMS, traditional Medicare, we've had very good luck with, and that they're approving everything and that everything's kind of pushing through. But with some of the Advantage plans and everything like that, that's where we've kind of come into some difficulties. And I wish I could tell the audience a trend or two that we've seen when it comes to denials. I can. It doesn't seem like one payer specifically is denying, but it seems that's where we're having more of our problems on a denial space.
One thing that I'll add too, I guess it's not directly responsive, but you need to think about the possibility of audits too, that even if a claim's not denied, it could be challenged later on.
Yeah, and I'd also like to add that when we see we may not see the exact rates, and I don't have rates of denials, but when we work with our clients on trying to improve, the realization of reimbursement payments, we say, well, it kind of may start with your screening process, your inclusion criteria for the RPM program in the first place. Are you doing what type of payers are you trying to align with, as well as what are you conducting an insurance verification and a pre-authorization screening prior to, and rather than just selecting patients that may all be under Medicare and just say, well, they have the clinical conditions that we're trying to monitor for, and let's push them all through. There may be differences in just how their particular coverage may be authorized or not. So to do a part of your screening process when you're enrolling patients, to screen out those that may not have a high chance of reimbursement, to remove those where you can.
Great. Well, thank you. So if we go to the next slide, Luke. We thought we'd talk about a couple of different things with you, some around partnership models. Then we wanted to talk about non-covered expenses, then value-based care, and then some outcomes. So why don't we start with the first question? What common collaborative partnership models have you seen be successful? And Rick, I'd like you to take the first run at this.
Thanks, Donna. Yeah, I'll just mention first some of the alternatives that are out there because there are various ways to structure arrangements with outside companies. One of the things that's pretty common is to have clinical staffing. So you've got an outside company that employs people who can actually monitoring what's happened with the patient. They can help set up the devices and make sure that the devices are appropriate. You also have software and hardware, kind of the platforms that are used to help manage the care. So you've got the whole IT, the HIT element of companies providing that. Also, you've got the use of RPM and RTM in order to support value-based payment and kind of clinically integrated networks. You also have the possibility of kind of medical device development if there are some unique aspects that need to be provided there, and also providing the medical device.
That's great. Thank you. Matt, how about if you talk to us a little bit about some considerations when you're selecting your partner?
Sure. So there's definitely some do's and don'ts in the space, both from selecting a technology vendor as well as looking at if you are going to go with one of the managed services or work with an outside group that's going to be working on your behalf. Number one, first and foremost, you need to make sure that you always have a written agreement, whether that's the vendor and or clinical group that you might be working with. That is important for any kind of audit protection against making sure that that is stated, as well as any kind of necessary roles and responsibilities and or who's doing what within the program. If somebody's just providing technology, or if there's an escalation process, is that in writing? That's just like a policy and procedure that you want to make sure you have in place. Also make sure that if you are working with outside management groups, that you have that statement of work, as well as have clarified whether or not they are properly licensed and or registered in the state that you are working with, and meet the clinical levels within what their call center might be doing. From the technology perspective, obviously you need to make sure that you are utilizing FDA approved devices, as well as want to make sure that from a compliance perspective that there are the proper checks in place, from everything from creating a care plan, the ability for you to make sure that you can capture consent, as well as the billing reports that are generated based on the CPT codes, that those are triggered correctly. There are sometimes changes, obviously, that happen depending on the types of insurance or how you're being covered. So you want to make sure that the reports that you're getting are going to align and protect you guys against any kind of OIG audit that might come in place.
Thank you. Mike, we're going to turn to you right now. How about if you tell us a little bit about value-based care, how the RPM and RTM has assisted with value-based care for your organization, as well as some of the cost benefit that you've seen?
Thanks, Donna. No, I think Bernie did an excellent synopsis on this earlier, is to kind of show the cost savings, because all of our managed care type of arrangements are really shifting towards away from fee for service to have that value-based care element. And really the ultimate thing that value-based care means is, can you provide efficient care, and can you save on any dollars to kind of help come back to the provider? And so I think what happens is number one, like Bernie alluded to, is the quality metrics. All these value-based care arrangements have quality metrics tied to them. So having the foresight and the proactivity to follow these patients helps us track the quality metrics, gets them into the clinic sooner. And then that way we can kind of track them and get all of our care gaps closed at the end of the day. That can lead to bonus dollars and can lead to you sharing in the savings that we can get in these types of arrangements, whether they're 50-50 deals or if you have at-risk deals. I would say the main thing that the payers seem to like with this, and that we like to provide the payers with this, is kind of reducing the costs and making sure that things are in the proper site of service. So right now, again, Bernie did an excellent job of kind of evaluating in his case study, is that reducing hospitalizations and reducing ED utilization, because ED is the gateway to hospitalization. So when we have these RPMs in place, we're able to monitor these patients, especially in our regard for our provider in our CHF environment, is we can monitor these patients after, God forbid, they have been admitted. We can see if sometimes it's something as simple as just medication adherence. They're taking the wrong medications or they're not taking the right amount of medications. We can course correct that based on what we're tracking, reach out to that patient, make sure that they correct what needs to be corrected and avoid a hospitalization, then ultimately a readmission, which we all know on this call, penalties and everything, how costly those can be at the end of the day. So I think, and then obviously we've had this shift towards population health. If the reason why RPMs and all this kind of stuff is up and coming is because we're trying to be proactive. We're trying to have a healthier population and kind of reduce spend in places where spend is able to be reduced. So I mean, I think that's the main thing, is that you can move this, and honestly, at the end of the day, it's convenient for the patient. No patient wants to be hospitalized. Going to the doctor is a tough thing. So having these kind of remote monitoring capabilities, the patient is able to get the care that they need and not necessarily have to be in the clinic unless they absolutely have to be.
Thanks, Mike. That was very, very helpful. So I'd like to ask Matt to talk to us a little bit about some operational workflows that have changed due to the use of RPM.
Sure. Yeah, one of the big things that a lot of organizations that we're working with actually have embedded the remote monitoring and care programs in general that the patient can do outside of the clinic into their everyday workflows for when the patient is actually coming in to see the doctor. And really what that just involves is either working through the administrators or the tools inside of either your RPM system and or EHR to identify potential eligible patients. And so during their appointment and encounter with the actual care provider, they can enroll them and gather consent. We've also had some organizations that have incorporated having some of the kits on hand in their inventory so that the patient's literally getting their 99453 and they're deployed with the device and educated on how to take the readings right there on the spot. Because you really have two ways of deploying. You either have a virtual model where you're shipping it and following up, and or you can do it right there on site. And we've actually seen improved adherence when that happens inside of a clinic versus a virtual model. It tends to be more effective.
That's great, thanks. Well, we couldn't have a session without talking about AI. So Bernie, how about if you talk to us a little bit about how you've seen AI flow within the changed workflows as you put RPM in?
Yeah, that's a real good question. I think we're still in the very early stages of that, but there's definitely progression and pathways towards AI and intelligence being built into RPM systems that I look at. Sort of automated intelligence is where it starts first, right? Where you can put some of these things that would normally be manually based into more automated processes, right? As well as building intelligence into conditional logic around, hey, if a certain event has occurred, then that can trigger a particular interaction that could be automated and not necessarily user driven and or manual, where for instance, a particular combination of a couple of answers to a questionnaire along with a high recorded value in a blood glucose reading or blood pressure reading could be assessed and combined into a triggered score that then produces a next level of engagement that could be automated with a patient, such as another questionnaire or another a text message to contact your provider, or to even a task for the care team that can be automated to say, okay, because of these, you should take these 3 steps in this order, and then as they're completed, each step updates and leads to the next based on the outcome of each prior step. So things like that we're building in already into the platforms, and then looking down the road more into more advanced AI with machine learning and that. But that's a little bit further down the road.
Yeah, and kind of to add to that, there's obviously, as Bernie mentioned, with the specific conditions, more and more patient engagement is obviously key to adherence. And with that is everything from reminders, but also gathering intelligence and data as it relates to the patient and how their program's going, if there's anything that they're reporting in terms of symptoms that might be missed. And that can allow for the ability to do an intervention prior to an emergent event. We've seen that happen with patients having different issues with their medications in the past that were identified through their vitals and just general symptom checking. But secondarily, to Bernie's point, you could also utilize it for more structured triage. We've leveraged tools in the past where they're able to actually go through and identify from the symptoms that were reported in those assessments actual answers of whether it's an emergent activity or is more of a false positive.
That's great. Luke, I want to turn it over to you because we had a couple of questions come into the Q&A area. So could you walk us through the first one, please?
Sure. During the presentation, Dr. Michael Reese asked about the estimates, Bernie, that you used for hourly time in terms of clinical staff. Can you talk about where that $35 an hour came from and how that applies to the analysis?
Yeah, great question. Thanks, Dr. Reese. So what we look at is the average rates for nurses across the country as one component of that. And they can range anywhere from the low 20s to as high as 60, for instance. So there's definitely a range in there. It depends on what part of the country you're in that. If you look at it, you might say, okay, 35 might be a bit low. There are estimates that say 35 per hour is average for a nurse, around 38 actually, and then maybe even 44 on the higher end. But what we also do is we look at, the RPM programs are not always staffed fully by nurses, right? So usually there could be a combination of RNs, LPNs, certified nurse assistants, and even medical assistants that are doing some of the initial dashboard checking of data, validating that it's correct, and doing the initial outreach, or even getting patients to try to take their reading. So a very lower credentialed person could be used in combination. So as a part of your staffing team, you could have a blend, and then that would more easily compute to very close to a mid-30s type of range. And we usually start from there, and if we need to adjust up or down, we do, and see the impact on the outcome.
Thanks, everybody. One more question from Patrick Simon in the chat. What standards and frameworks are being used or plan to be used to mitigate artificial intelligence risk and cybersecurity attacks and compromise of PHI, RPM, and health data, all of the above? This is a very large question, I'm sure, but maybe the most succinct answer you can give.
Yeah, one of the most common that's utilized is obviously through integration directly into the EHRs of the organizations, utilizing the security protocols, the data management that is going on in place. Obviously, sometimes we'll see vendors themselves also have things like SOC 2 or high trust. But in the integrated model, that tends to be more on par with what the actual security protocols that the organization themselves have put in place from an IT security standpoint. So that's oftentimes where, especially in the larger organizations or ones that aren't just acting as independent, will move towards that. But when it comes to data management, most systems out there today are going to be somewhere in the cloud in terms of like an AWS or Microsoft, and can leverage those microservices as well for protection and data security.
Yeah, Patrick has a follow-up that the data will be transient or in transit as well.
Correct.
Yeah, and
Yeah.
we apply, I mean, I think most RPM vendors, but we apply encryption for data at rest and data in transit, as it crosses in our case, cellular connectivity directly from the device to the platform in the cloud. We host on Microsoft Azure in a SOC 2 environment too, and we have high trust, but the data is encrypted as it moves through the network and in transit as well.
And yeah, I don't have a specific kind of response specific to the AI, but I think it's just important to keep in mind, just as kind of fundamental issues, that it's really important to make sure that that there's that there's a risk analysis done regularly and updated regularly to account for all the access, every place where the where information is, sensitive information, patient information is stored, where it's transmitted, how it's transmitted, and to to just take a good look at how all this relates. So for example, like even if the EHR may be relatively secure, how does the information get to and from the EHR? So I think you've got more and more, especially as more people get involved and more organizations get involved, you have more places where information can be accessed and things could potentially be hacked, or something can get compromised in some way.
Luke,
Patrick has a couple
ahead.
follow-ups here in the chat. We only have about 4 minutes here remaining on our time, but yeah, I mean, obviously taking into account quantum computing and other end-to-end like solutions that need to account for like the evolving nature of risk is obviously going to be something that we as an industry are going to have to pursue cross-sectorally, I'm sure. I'm just not sure if we have all of the time to get into that, but I do want to make sure that everybody knows before we add any questions to the slate here that these slides will be packaged and sent out to attendees and registrants at a later date, and the video on demand will be housed on both the Upper Midwest Telehealth Resource Center site and our YouTube channel, as well as the Partnership for Connected Illinois site.
Great. And in the last few minutes that we have, are there any other questions that we can answer for you?
I'll add one little extra tidbit just from more of a protecting of what to consider. If anybody's ever offering you something for free, that's one where you want to run. So there's nothing free in the world of delivering services or vendors. And so that's one of those things that is sometimes thrown around in the industry, whether it's free devices or free this. Be cautious of that when you're contracting with that type of group.
We saw a lot of that in the early stages of COVID when there were a lot of vendors everywhere. And so after about a year, we would go back in to help clients look at what they chose and if it was still working, and if not, what they needed to move to. So helping them with the strategy. So that's very true, Matt. Well, I think that's the end of our session. Luke, I'm going to turn it over to you.
Yeah, I will just reiterate that we will post the video on demand of this recording once it's available, and we get it housed on both the Partnership for Connected Illinois website as well as the Upper Midwest Telehealth Resource Center site. I want to thank our wonderful panel of speakers today, Bernie, Matt, Rick, Donna, and Mike, and also all of the folks who helped support the event to make it happen today. Thank you so much.
Oh, and yeah, I'll just add too, thank you very much to Upper Midwest Telehealth Resource Center and Luke for hosting this and kind of making this possible. And also, I'll also mention our supporting organizations: Illinois Health and Hospital Association, Illinois Primary Healthcare Association, and Illinois Association of Healthcare Attorneys. Thank you.
Well, that concludes our session today. We can absolutely, if you want to stick around after the recording has ended, we will post all of that contact information in the chat if you want to get a hold of any of our presenters directly. I will also post my contact information in the chat for the Upper Midwest Telehealth Resource Center. As a reminder, we are a federally funded technical assistance center. We're here for your TA questions, whether that's basic implementation or really thorny billing and coding questions, all the way to individual outreach, education, and training. Thank you so much for attending today.
Thank you, everybody.
Thank you. Bye-bye.
Thanks, everyone.